Section 17 of Gray's Anatomy, Part 1. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Jennifer Stearns. Anatomy of the Human Body, Part 1 by Henry Gray. The Thorax. The skeleton of the thorax or chest is an osseo-cartilaginous cage, containing and protecting the principal organs of respiration and circulation. It is conical in shape, being narrow above and broad below, flattened from before backward, and longer behind than in front. It is somewhat reniform on transverse section on account of the projection of the vertebral bodies into the cavity. Boundaries. The posterior surface is formed by the 12 thoracic vertebrae and the posterior parts of the ribs. It is convex from above downward and presents on either side of the middle line a deep groove, in consequence of the lateral and backward direction which the ribs take from the vertebral extremities to their angles. The anterior surface, formed by the sternum and costal cartilages, is flattened and slightly convex, and inclined from above downward and forward. The lateral surfaces are convex. They are formed by the ribs, separated from each other by the intercostal spaces, 11 in number, which are occupied by the intercostal muscles and membranes. The upper opening of the thorax is reniform in shape, being broader from side to side than from before backward. It is formed by the first thoracic vertebra behind, the upper margin of the sternum in front, and the first rib on either side. It slopes downward and forward, so that the anterior part of the opening is on a lower level than the posterior. Its antero-posterior diameter is about 5 cm, and its transverse diameter about 10 cm. The lower opening is formed by the 12th thoracic vertebra behind, by the 11th and 12th ribs at the sides, and in front by the cartilages of the 10th, 9th, 8th, and 7th ribs, which ascend on either side and form an angle, the subcostal angle, into the apex of which the xiphoid process projects. The lower opening is wider transversely than from before backward, and slopes obliquely downward and backward. It is closed by the diaphragm, which forms the floor of the thorax. The thorax of the female differs from that of the male as follows: 1. Its capacity is less. 2. The sternum is shorter. 3. The upper margin of the sternum is on a level with the lower part of the body of the 3rd thoracic vertebra, whereas in the male it is on a level with the lower part of the body of the 2nd. 4. The upper ribs are more movable, and so allow a greater enlargement of the upper part of the thorax. The sternum. Breastbone. The sternum is an elongated flattened bone forming the middle portion of the anterior wall of the thorax. Its upper end supports the clavicles, and its margins articulate with the cartilages of the first 7 pairs of ribs. It consists of 3 parts, named from above downward: the manubrium, the body or gladiolus, and the xiphoid process. In early life the body consists of 4 segments or sternebrae. In its natural position the inclination of the bone is oblique from above, downward and forward. It is slightly convex in front and concave behind, broad above, becoming narrowed at the point where the manubrium joins the body, after which it again widens a little below the middle of the body, and then narrows to its lower extremity. Its average length in the adult is about 17 cm, and is rather greater in the male than in the female. Manubrium. Manubrium sterni. The manubrium is of a somewhat quadrangular form, broad and thick above, narrow below at its juncture with the body. Surfaces. Its anterior surface, convex from side to side, concave from above downward, is smooth, and affords attachment on either side to the sternal origins of the pectoralis major and sternocleidomastoidus. Sometimes the ridges limiting the attachments of these muscles are very distinct. Its posterior surface, concave and smooth, affords attachment on either side to the sternohyoidus and sternothyreoids. Borders. The superior border is the thickest, and presents at its center the jugular or presternal notch. On either side of the notch is an oval articular surface, directed upward, backward, and lateralward, for articulation with the sternal end of the clavicle. The inferior border, oval and rough, is covered in a fresh state with a thin layer of cartilage, for articulation with the body. The lateral borders are each marked above by a depression for the first costal cartilage, and below by a small facet, which, with a similar facet on the upper angle of the body, forms a notch for the reception of the costal cartilage of the second rib. Between the depression for the first costal cartilage and the demi-facet for the second is a narrow curved edge, which slopes from above downward and medialward. Body. Corpus sterni. Gladiolus. The body, considerably longer, narrower, and thinner than the manubrium, attains its greatest breadth close to the lower end. Surfaces. Its anterior surface is nearly flat, directed upward and forward, and marked by three transverse ridges, which cross the bone opposite the third, fourth, and fifth articular depressions. Footnote: Patterson, The Human Sternum, 1904, who examined 524 specimens, points out that these ridges are altogether absent in 23.7%, that in 69% a ridge exists opposite the third costal attachment, and 39% opposite the fourth, 4% only opposite the fifth. End footnote. It affords attachment on either side of the sternal origin of the pectoralis major. At the junction of the third and fourth pieces of the body is occasionally seen an orifice, the sternal foramen, of varying size and form. The posterior surface, slightly concave, is also marked by three transverse lines, less distinct, however, than those in front. From its lower part on either side, the transversus thoracis takes origin. Borders. The superior border is oval and articulates with the manubrium junction of the two forming the sternal angle, angulus Ludovici. Footnote: Named after the French surgeon Antoine Louis, 1723 1792. The Latin name angulus Ludovici is not infrequently mistranslated into English as the angle of Ludwig. End footnote. The inferior border is narrow and articulates with the xiphoid process. Each lateral border at its superior angle has a small facet, with which a similar facet on the manubrium forms a cavity for the cartilage of the second rib. Below this are four angular depressions, which receive the cartilages of the third, fourth, fifth, and sixth ribs, while the inferior angle has a small facet, which, with a corresponding one on the xiphoid process, forms a notch for the cartilage of the second rib. These articular depressions are separated by a series of curved interarticular intervals, which diminish in length from above downward, and correspond to the intercostal spaces. Most of the cartilages belong to the true ribs, as will be seen from the foregoing description, articulate with the sternum at the lines of junction of its permuted component segments. This is well seen in many of the lower animals, where the parts of the bone remain ununited longer than in man. Xiphoid process. Processus xiphoideus. Ensiform or xiphoid appendix. The xiphoid process is the smallest of the three pieces. It is thin and elongated, cartilaginous in structure in youth, but more or less ossified at its upper part in the adult. Surfaces. Its anterior surface affords attachment on either side to the anterior costoxiphoid ligament, and a small part of the rectus abdominis, its posterior surface, to the posterior costoxiphoid ligament, and to some of the fibers of the diaphragm and transversus thoracis, its lateral borders, to the aponeurosis of the abdominal muscles. Above, it articulates with the lower end of the body, and on the front of each superior angle presents a facet for part of the cartilage of the seventh rib. Below, by its pointed extremity, it gives attachment to the linea alba. The xiphoid process varies much in form. It may be broad and thin, pointed, bifid, perforated, curved, or deflected considerably to one or other side. Structure. The sternum is composed of highly vascular cancellous tissue, covered by a thin layer of compact bone, which is thickest in the manubrium between the articular facets for the clavicles. Ossification. The sternum originally consists of two cartilaginous bars, situated one on either side of the median plane and connected with the cartilages of the upper 9 ribs of its own side. These two bars fuse with each other along the middle line to form the cartilaginous sternum, which is ossified from 6 centers, 1 for the manubrium, 4 for the body, and 1 for the xiphoid process. The ossific centers appear in the intervals between the articular depressions for the costal cartilages, in the following order: in the manubrium and first piece of the body during the 6th month, in the second and third pieces of the body during the 7th month of fetal life, in its fourth piece during the first year after birth, and in the xiphoid process between the 5th and 18th years. The centers make their appearance at the upper parts of the segments and proceed gradually downward. Footnote: out of 141 sterna between the time of birth and the age of 16 years, Patterson found the fourth or lowest center for the body present only in 38 cases, that is, 26.9%. End footnote. To these may be added the occasional existence of 2 small episternal centers, which make their appearance one on either side of the jugular notch. They are probably vestiges of the episternal bone of the monotremata and lizards. Occasionally some of the segments are formed from more than one center, the number and position of which vary. Thus the first piece may have 2, 3, or even 6 centers. When 2 are present, they are generally situated one above the other, the upper being the larger. The second piece has seldom more than 1. The third, fourth, and fifth pieces are often formed from 2 centers placed laterally, the irregular union of which explains the rare occurrence of the sternal foramen, or of the vertical fissure which occasionally intersects this part of the bone, constituting the malformation known as fissura sterni. These conditions are further explained by the manner in which the cartilaginous sternum is formed. More rarely still, the upper end of the sternum may be divided by a fissure. Union of the various centers of the body begins about puberty, and proceeds from below upward. By the age of 25 they are all united. The xiphoid process may become joined to the body before the age of 30, but this occurs more frequently after 40. On the other hand, it sometimes remains ununited in old age. In advanced life the manubrium is occasionally joined to the body by bone. When this takes place, however, the body tissue is generally only superficial. The central portion of the interfering cartilage remains unossified. Articulations. The sternum articulates on either side with the clavicle and upper 7 costal cartilages. End of section 17. Recording by Jennifer Stearns, Concord, New Hampshire. 18 of Gray's Anatomy, Part 1. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Jennifer Stearns. Anatomy of the Human Body, Part 1, by Henry Gray. Section 18. The Ribs. Costae. The ribs are elastic arches of bone which form a large part of the thoracic skeleton. They are 12 in number on either side, but this number may be increased by the development of a cervical or lumbar rib, or may be diminished to 11. The first 7 are connected behind with a vertebral column, and in front, through the intervention of the costal cartilages, with the sternum. They are called true or vertebro-sternal ribs. Footnote: sometimes the 8th rib cartilage articulates with the sternum. This condition occurs more frequently on the right than on the left side. End footnote. The remaining 5 are false ribs. Of these, the first 3 have the cartilages attached to the cartilage of the rib above, vertebrochondral. The last 2 are free at their anterior extremities and are termed floating or vertebral ribs. The ribs vary in their direction, the upper ones being less oblique than the lower. The obliquity reaches its maximum at the 9th rib, and gradually decreases from that rib to the 12th. The ribs are situated one below the other in such a manner that spaces called intercostal spaces are left between them. The length of each space corresponds to that of the adjacent ribs and their cartilages. The breadth is greater in front than behind, and between the upper and the lower ribs. The ribs increase in length from the first to the seventh, below which they diminish to the 12th. In breadth they decrease from above downward. In the upper 10 the greatest breadth is at the sternal extremity. Common characteristics of the ribs. A rib from the middle of the series should be taken in order to study the common characteristics of these bones. Each rib has two extremities, a posterior or vertebral and an anterior or sternal, and in intervening portion the body or shaft. Posterior extremity. The posterior or vertebral extremity presents for examination a head, neck, and tubercle. The head is marked by a kidney-shaped articular surface, divided by a horizontal crest into two facets for articulation, with a depression formed on the bodies of two adjacent thoracic vertebrae. The upper facet is the smaller. To the crest is attached the interarticular ligament. The neck is the flattened portion which extends lateralward from the head. It is about 2.5 cm long and is placed in front of the transverse process of the lower of the two vertebrae with which the head articulates. Its anterior surface is flat and smooth, its posterior rough for the attachment of the ligament of the neck, and perforated by numerous foramina. Of its two borders, the superior presents a rough crest, crista colle costo, for the attachment of the anterior costo-transverse ligament. Its inferior border is rounded. On the posterior surface, at the juncture of the neck and body, and nearer the lower than the upper border, is an eminence, the tubercle. It consists of an articular and non-articular portion. The articular portion, the lower and more medial of the two, presents a small oval surface for articulation with the end of the transverse process of the lower of the two vertebrae to which the head is connected. The non-articular portion is a rough elevation, and affords attachment to the ligament of the tubercle. The tubercle is much more prominent in the upper than in the lower ribs. Body. The body or shaft is thin and flat, with two surfaces, an external and an internal, and two borders, a superior and an inferior. The external surface is convex, smooth, and marked, a little in front of the tubercle, by a prominent line. Directed downward and lateralward, this gives attachment to a tendon of the iliocostalis, and is called the angle. At this point the rib is bent in two directions, and at the same time twisted on its long axis. If the rib be laid upon its lower border, the portion of the body in front of the angle rests upon this border, while the portion behind the angle is bent medialward and at the same time tilted upward. As the result of the twisting, the external surface behind the angle looks downward, and in front of the angle slightly upward. The distance between the angle and the tubercle is progressively greater from the second to the 10th ribs. The portion between the angle and the tubercle is rounded, rough, and irregular, and serves for the attachment of the longissimus dorsi. The internal surface is concave, smooth, directed a little upward behind the angle, a little downward in front of it, and is marked by a ridge which commences at the lower extremity of the head. This ridge is strongly marked as far as the angle, and gradually becomes lost at the junction of the anterior and middle thirds of the bone. Between it and the inferior border is a groove, the costal groove, for the intercostal vessels and nerve. At the back part of the bone, this groove belongs to the inferior border, but just in front of the angle, where it is deepest and broadest, it is on the internal surface. The superior edge of the groove is rounded, and serves for the attachment of an intercostalis internus. The inferior edge corresponds to the lower margin of the rib, and gives attachment to an intercostalis externus. Within the groove are seen the orifices of numerous small foramina for nutrient vessels which traverse the shaft obliquely from before backward. The superior border, thick and rounded, is marked by an external and an internal lip, more distinct behind than in front, which serve for the attachment of intercostalis externus and internus. The inferior border is thin, and has attached to it an intercostalis externus. Anterior extremity. The anterior or sternal extremity is flattened and presents a porous, oval, concave depression into which the costal cartilage is received. Peculiar ribs. The first, second, 10th, 11th, and 12th ribs present certain variations from the common characteristics described above, and require special consideration. First rib. The first rib is the most curved and usually the shortest of all the ribs. It is broad and flat, its surfaces looking upward and downward, and its borders inward and outward. The head is small, rounded, and possesses only a single articular facet, for articulation with the body of the first thoracic vertebra. The neck is narrow and rounded. The tubercle, thick and prominent, is placed on the outer border. There is no angle, but at the tubercle the rib is slightly bent, with its convexity upward, so that the head of the bone is directed downward. The upper surface of the body is marked by two shallow grooves, separated from each other by a slight ridge prolonged internally into a tubercle, the scalene tubercle, for the attachment of the scalenus anterior. The anterior groove transmit the subclavian vein, the posterior and subclavian artery, and the lowest trunk of the brachial plexus. Behind the posterior groove is a rough area for the attachment of the scalenus medius. The under surface is smooth and destitute of a costal groove. The outer border is convex, thick, and rounded, and at its posterior part gives attachment to the first digitation of the serratus anterior. The inner border is concave, thin and sharp, and marked about its center by the scalene tubercle. The anterior extremity is larger and thicker than that of any of the other ribs. The second rib. The second rib is much longer than the first, but has a very similar curvature. The non-articular portion of the tubercle is occasionally only feebly marked. The angle is slight and situated close to the tubercle. The body is not twisted, so that both ends touch any plane surface upon which it may be laid, but there is a bend, with its convexity upward, similar to, though smaller than, that found in the first rib. The body is not flattened horizontally like that of the first rib. Its external surface is convex, and looks upward and a little outward. Near the middle of it is a rough eminence for the origin of the lower part of the first and the whole of the second digitation of the serratus anterior. Behind and above this is attached the scalenus posterior. The internal surface, smooth and concave, is directed downward and a little inward. On its posterior part there is a short costal groove. Tenth rib. The tenth rib has only a single articular facet on its head. 11th and 12th ribs. The 11th and 12th ribs have each a single articular facet on the head, which is of rather large size. They have no necks or tubercles, and are pointed at their anterior ends. The 11th has a slight angle and a shallow costal groove. The 12th has neither. It is much shorter than the 11th, and its head is inclined slightly downward. Sometimes the 12th rib is even shorter than the first. Structure. The ribs consist of highly vascular cancellous tissue, enclosed in a thin layer of compact bone. Ossification. Each rib, with the exception of the last two, is ossified from 4 centers, a primary center for the body, and 3 epiphyseal centers, 1 for the head, and 1 each for the articular and non-articular parts of the tubercle. The 11th and 12th ribs have each only 2 centers, those for the tubercles being wanting. Ossification begins near the angle toward the end of the second month of fetal life, and is seen first in the 6th and 7th ribs. The epiphyses for the head and tubercle make their appearance between the 16th and 20th years, and are united to the body about the 25th year. Fawcett states that in all probability there is usually no epiphysis on the non-articular part of the tuberosity below the 6th or 7th rib. End of section 18. Recording by Jennifer Stearns, Concord, New Hampshire. Section 19 of Gray's Anatomy Part 1. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Jennifer Stearns. Anatomy of the Human Body, Part 1, by Henry Gray. Section 19. The costal cartilages. Cartilaginous costalis. The costal cartilages are bars of hyaline cartilage which serve to prolong the ribs forward and contribute very materially to the elasticity of the walls of the thorax. The first 7 pairs are connected with the sternum. The next 3 are each articulated with the lower border of the cartilage of the preceding rib. The last 2 have pointed extremities, which end in the wall of the abdomen. Like the ribs, the costal cartilages vary in their length, breadth, and direction. They increase in length from the first to the 7th, then gradually decrease to the 12th. Their breadth, as well as that of the intervals between them, diminishes from the first to the last. They are broad in their attachments to the ribs, and taper toward their sternal extremities, excepting the first 2, which are of the same breadth throughout, and the 6th, 7th, and 8th, which are enlarged where their margins are in contact. They also vary in direction. The first descends a little, the second is horizontal, the third ascends slightly, while the others are angular, following the course of the ribs for a short distance, and then ascending to the sternum or preceding cartilage. Each costal cartilage presents 2 surfaces, 2 borders, and 2 extremities. Surfaces. The anterior surface is convex, and looks forward and upward. That of the first gives attachment to the costal clavicular ligament and the subclavius muscle. Those of the first 6 or 7, at their sternal ends, to the pectoralis major. The others are covered by, and give partial attachment to, some of the flat muscles of the abdomen. The posterior surface is concave, and directed backward and downward. That of the first gives attachment to the sternothyroides, those of the third to the 6th inclusive of the transversus thoracis, and the 6 or 7 inferior ones to the transversus abdominis and the diaphragm. Borders. Of the 2 borders the superior is concave, the inferior convex. They afford attachment to the intercostalis interni. The upper border of the 6 gives attachment also to the pectoralis major. The inferior borders of the 6th, 7th, 8th, and 9th cartilages present heel-like projections at the points of greatest convexity. These projections carry smooth oblong facets, which articulate respectively with facets and slight projections from the upper borders of the 7th, 8th, 9th, and 10th cartilages. Extremities. The lateral end of each cartilage is continuous with the osseous tissue of the rib to which it belongs. The medial end of the first is continuous with the sternum. The medial ends of the 6 succeeding ones are rounded and are received into shallow concavities on the lateral margins of the sternum. The medial ends of the 8th, 9th, and 10th costal cartilages are pointed, and are connected each with a cartilage immediately above. Those of the 11th and 12th are pointed and free. In old age the costal cartilages are prone to undergo superficial ossification. Cervical ribs, derived from the 7th cervical vertebra, are of not infrequent occurrence, and are important clinically because they may give rise to obscure nervous or vascular symptoms. The cervical rib may be a mere epiphysis, articulating only with the transverse process of the vertebra, but more commonly it consists of a defined head, neck, and tubercle, with or without a body. It extends lateralward, or forward and lateralward, into the posterior triangle of the neck, where it may terminate in a free end or may join the first thoracic rib, the first costal cartilage, or the sternum. It varies much in shape, size, direction, and mobility. If it reach far enough forward, part of the brachial plexus and the subclavian artery and vein cross over it, and are apt to suffer compression in so doing. Pressure on the artery may obstruct the circulation so much that arterial thrombosis results, causing gangrene of the fingertips. Pressure on the nerves is commoner, and affects the 8th cervical and 1st thoracic nerves. causing paralysis of the muscles they supply, and neuralgic pain and paresthesia in the area of skin to which they are distributed. No ocular pupillary changes are to be found. The thorax is frequently found to be altered in shape in certain diseases. In rickets, the ends of the ribs, where they join the costal cartilages, become enlarged, giving rise to the so-called rickety rosary, which in mild cases is only found on the internal surface of the thorax. Lateral to these enlargements, the softened ribs sink in, so as to present a groove passing downward and lateralward on either side of the sternum. This bone is forced forward by the bending of the ribs, and the antero-posterior diameter of the chest is increased. The ribs affected of the second to the eighth, the lower ones being prevented from falling in by the presence of the liver, stomach, and spleen, and when the abdomen is distended, as it often is in rickets, the lower ribs may be pushed outward, causing a transverse groove, Harrison's sulcus, just above the costal arch. This deformity, or forward projection of the sternum, often asymmetrical, is known as pigeon breast, and may be taken as evidence of active or old rickets, except in cases of primary spinal curvature. In many instances it is associated in children with obstruction in the upper air passages, due to enlarged tonsils or adenoid growths. In some rickety children or adults, and also in others who give no history or further evidence of having had rickets, an opposite condition obtains. The lower part of the sternum, and often the xiphoid process as well, are deeply depressed backward, producing an oval hollow in the lower sternal and upper epigastric regions. This is known as funnel breast (German, Treckerbrust), and never appears to produce the least disturbance of any of the vital functions. The fistical chest is often long and narrow, and with great obliquity of the ribs and projection of the scapulae. In pulmonary emphysema the chest is enlarged in all its diameters, and presents on section an almost circular outline. It has received the name of the barrel-shaped chest. In severe cases of lateral curvature of the vertebral column, the thorax becomes much distorted. In consequence of the rotation of the bodies of the vertebra, which takes place in this disease, the ribs opposite the convexity of the dorsal curve become extremely convex behind, being thrown out and bulging, and at the same time flattened in front, so that the two ends of the same rib are almost parallel. Coincidently with this, the ribs on the opposite side, on the concavity of the curve, are sunk and depressed behind, and bulging and convex in front. End of section 19. Recording by Jennifer Stearns, Concord, New Hampshire. Section 20 of Gray's Anatomy, Part 1. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Jennifer Stearns. Anatomy of the Human Body, Part 1, by Henry Gray. Section 20. The Skull. The skull is supported on the summit of the vertebral column, and is of an oval shape, wider behind than in front. It is composed of a series of flattened or irregular bones which, with one exception, the mandible, are immovably jointed together. It is divisible into two parts. One, the cranium, which lodges and protects the brain, consists of 8 bones, and 2, the skeleton of the face, of 14, as follows: skull, 22 bones; cranium, 8 bones; occipital, 2 parietals; frontal, 2 temporals; sphenoidal, ethmoidal; face, 14 bones; 2 nasals, 2 maxillae, 2 lacrymals, 2 zygomatics, 2 palatines, 2 inferior nasal conchae, vomer, mandible. In the basal nomenclature, certain bones developed in association with the nasal capsule, the inferior nasal conchae, the lacrymals, the nasals, and the vomer, are grouped as cranial and not as facial bones. The hyoid bone, situated at the root of the tongue and attached to the base of the skull by ligaments, is described in this section.
the occipital bone, ossa cranii, and os occipitale. The occipital bone, situated at the back and lower part of the cranium, is trapezoid in shape and curved on itself. It is pierced by a large oval aperture, the foramen magnum, through which the cranial cavity communicates with the vertebral canal. The curved expanded plate behind the foramen magnum is named the squama. The thick, somewhat quadrilateral piece in front of the foramen is called the basilar part, whilst on either side of the foramen is the lateral portion, the squama, squama occipitalis. The squama, situated above and behind the foramen magnum, is curved from above downward and from side to side. Surfaces. The external surface is convex and presents midway between the summit of the bone and the foramen magnum a prominence, the external occipital protuberance. Extending lateralward from this on either side are two curved lines, one a little above the other. The upper, often faintly marked, is named the highest neutral line, and to it the galea aponeurotica is attached. The lower is termed the superior neutral line. That part of the squama which lies above the highest neutral lines is named the planum occipitale, and is covered by the occipitalis muscle. That below, termed the planum nuchale, is rough and irregular for the attachment of several muscles. From the external occipital protuberance, a ridge or crest, the median neutral line, often faintly marked, descends to the foramen magnum, and affords attachment to the ligamentum nuchae. Running from the middle of this line across either half of the neutral plane is the inferior neutral line. Several muscles are attached to the outer surface of the squama. Thus the superior neutral line gives origin to the occipitalis trapezius, and insertion to the sternocleidomastoides and splenius capitis. Into the surface between the superior and inferior neutral lines, semispinalis capitis and the obliquus capitis superior are inserted, while the inferior neutral line and the area below it receive the insertions of the recti capitis posterioris major and minor. The posterior atlanto-occipital membrane is attached around the posterolateral part of the foramen magnum, just outside the margin of the foramen. The internal surface is deeply concave and divided into four fossae cruciate eminence. The upper two fossae are triangular and lodge the occipital bones of the cerebrum. The lower two are quadrilateral and accommodate the hemispheres of the cerebellum. At the point of intersection of the four divisions of the cruciate eminence is the internal occipital protuberance. From this protuberance, the upper division of the cruciate eminence runs to the superior angle of the bone, and on one side of it, generally the right, is a deep groove, the sagittal sulcus, which lodges the hinder part of the superior sagittal sinus. To the margins of this sulcus the falx cerebri is attached. The lower division of the cruciate eminence is prominent, and is named the internal occipital crest. It bifurcates near the foramen magnum, and gives attachment to the falx cerebelli. In the attached margin of this falx is the occipital sinus, which is sometimes duplicated. In the upper part of the internal occipital crest, a small depression is sometimes distinguishable. It is termed the foramen fossa, since it is occupied by part of the vermis of the cerebellum. Transverse grooves, one on either side, extend from the internal occipital protuberance to the lateral angles of the bone. Those grooves accommodate the transverse sinuses, and their prominent margins give attachment to the tentorium cerebelli. The groove on the right side is usually larger than that on the left, and is continuous with that for the superior sagittal sinus. Exceptions to this condition are, however, not infrequent. The left may be larger than the right, or the two may be almost equal in size. The angle of union of the superior sagittal and transverse sinuses is named the confluence of the sinuses. Torcular hierophili. Footnote. The columns of blood coming in different directions were supposed to be pressed together at this point, torcular, a wine press.] and its position is indicated by a depression situated on one or other side of the protuberance. Lateral parts, pars lateralis. The lateral parts are situated at the sides of the foramen magnum. On their under surfaces are the condyles for articulation with the superior facets of the atlas. The condyles are oval or reniform in shape, and their anterior extremities, directed forward and medialward, are closer together than their posterior, and encroach on the basilar portion of the bone. The posterior extremities extend back to the level of the middle of the foramen magnum. The articular surfaces of the condyles are convex from before backward and from side to side, and look downward and lateralward. To their margins are attached the capsules of the atlanto-occipital articulations, and on the medial side of each is a rough impression or tubercle for the alar ligament. At the base of either condyle, the bone is tunneled by a short canal, the hypoglossal canal, anterior condyloid foramen. This begins on the cranial surface of the bone immediately above the foramen magnum, and is directed lateralward and forward above the condyle. It may be partially or completely divided into two by a spicule of bone. It gives exit to the hypoglossal or 12th cerebral nerve, and entrance to a meningeal branch of the ascending pharyngeal artery. Behind either condyle is a depression, the condyloid fossa, which receives the posterior margin of the superior facet of the atlas when the head is bent backward. The floor of this fossa is sometimes perforated by the condyloid canal, through which an emissary vein passes from the transverse sinus. Extending lateralward from the posterior half of the condyle is a quadrilateral plate of bone, the jugular process, excavated in front by the jugular notch, which, in the articulated skull, forms the posterior part of the jugular foramen. The jugular notch may be divided into two by a bony spicule, the intrajugular process, which projects lateralward above the hypoglossal canal. The under surface of the jugular process is rough, and gives attachment to the rectus capitis lateralis muscle and the lateral atlanto-occipital ligament. From this surface in eminence, the paramastoid process sometimes projects downwards, and may be of sufficient length to reach and articulate with the transverse process of the atlas. Laterally, the jugular process presents a rough quadrilateral or triangular area, which is joined to the jugular surface of the temporal bone by a plate of cartilage. After the age of 25, this plate tends to ossify. The upper surface of the lateral part presents an oval eminence, the jugular tubercle, which overlies the hypoglossal canal, and is sometimes crossed by an oblique groove for the glossopharyngeal, vagus, and accessory nerves. On the upper surface of the jugular process is a deep groove which curves medialward and forward and is continuous with the jugular notch. This groove lodges the terminal part of the transverse sinus, and opening into it, close to the medial margin, is the orifice of the condyloid canal. Basilar part, pars basilaris. The basilar part extends forward and upward from the foramen magnum, and presents in front an area more or less quadrilateral in outline. In the young skull, this area is rough and uneven, and is joined to the body of the sphenoid by a plate of cartilage. By the 25th year, this cartilaginous plate is ossified, and the occipital and sphenoid form a continuous bone. Surfaces. On its lower surface, about 1 centimeter in front of the foramen magnum, is the pharyngeal tubercle, which gives attachment to the fibrous raphe of the pharynx. On either side of the middle line, the longus capitis and rectus capitis anterior are inserted, and immediately in front of the foramen magnum, the anterior atlanto-occipital membrane is attached. The upper surface presents a broad, shallow groove, which inclines upward and forward from the foramen magnum. It supports the medulla oblongata and near the margin of the foramen magnum gives attachment to the membrana tectoria. On the lateral margins of this surface are faint grooves for the inferior petrosal sinuses. Foramen magnum. The foramen magnum is a large oval aperture with its long diameter anterior-posterior. It is wider behind than in front, where it is encroached upon by the condyles. It transmits the medulla oblongata and its membranes, the accessory nerves, the vertebral arteries, the anterior and posterior spinal arteries, and the membrana tectoria and alar ligaments. Angles. The superior angle of the occipital bone articulates with the occipital angles of the parietal bones, and, in the fetal skull, corresponds in position with the posterior fontanelle. The inferior angle is fused with the body of the sphenoid. The lateral angles are situated at the extremities of the grooves for the transverse sinuses. Each is received into the interval between the mastoid angle of the parietal and mastoid part of the temporal. Borders. The superior borders extend from the superior to the lateral angles. They are deeply serrated for articulation with the occipital borders of the parietals, and form by this union the lambdoidal suture. The inferior borders extend from the lateral angles to their inferior angle. The upper half of each articulates with the mastoid portion of the corresponding temporal, the lower half with the petrous part of the same bone. These two portions of the inferior border are separated from one another by the jugular process, the notch on the anterior surface of which forms the posterior part of the jugular foramen. Structure. The occipital, like the other cranial, the outer and inner tables, between which is the cancellous tissue or diploid. The bone is especially thick at the ridges, protuberances, condyles, and an anterior part of the basilar part. In the inferior fossae it is thin, semi-transparent, and destitute of diploid. Ossification. The planum occipitale of the squama is developed in membrane, and may remain separate throughout life when it constitutes the interparietal bone. The rest of the bone is developed in cartilage. The number of nuclei for the planum occipitale is usually given as 4, 2 appearing near the middle line about the 2nd month, and 2 some little distance from the middle line about the 3rd month of fetal life. The planum nuchale of the squama is ossified from 2 centers, which appear about the 7th week of fetal life, and soon unite to form a single piece. Union of the upper and lower portions of the squama takes place in the 3rd month of fetal life. An occasional center, Kirchrig, appears in the posterior margin of the foramen magnum during the 5th month. This forms a separate ossicle, sometimes double, which unites with the rest of the squama before birth. Each of the lateral parts begins to ossify from a single center during the 8th week of fetal life. The basilar portion is ossified from 2 centers, one in front of the other. These appear by the 6th week of fetal life and rapidly coalesce. Moll states that the planum occipitale is ossified from 2 centers and the basilar portion from 1. About the 4th year, the squama and the 2 lateral portions unite, and about the 6th year the bone consists of a single piece. Between the 18th and 25th years, the occipital and sphenoid become united, forming a single bone. End of section 20. Recording by Jennifer Stearns, Concord, New Hampshire.
Of Gray's Anatomy, Part 1. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information, or to volunteer, please visit LibriVox.org. Recording by Jennifer Stearns. Anatomy of the Human Body, Part 1, by Henry Gray. The parietal bone. Os parietale. The parietal bones form by their union the sides and roof of the cranium. Each bone is irregularly quadrilateral in form and has 2 surfaces, 4 borders, and 4 angles. Surfaces. The external surface is convex, smooth, and marked near the center by an eminence, the parietal eminence, tuber parietale, which indicates the point where ossification commenced. Crossing the middle of the bone in an arched direction are two curved lines, the superior and inferior temporal lines. The former gives attachment to the temporal fascia, and the latter indicates the upper limit of the muscular origin of the temporalis. Above these lines the bone is covered by the galea aponeurotica. Below them it forms part of the temporal fossa, and affords attachment to the temporalis muscle. At the back part and close to the upper or sagittal border is the parietal foramen, which transmit a vein to the superior sagittal sinus, and sometimes a small branch of the occipital artery. It is not constantly present, and its size varies considerably. The internal surface is concave. It presents depressions corresponding to the cerebral convolutions, and numerous furrows for the ramifications of the middle meningeal vessel. The latter run upward and backward from the sphenoidal angle, and from the central and posterior part of the squamous border. Along the upper margin is a shallow groove, which, together with that on the opposite parietal, forms a channel, the sagittal sulcus, for the superior sagittal sinus. The edges of the sulcus afford attachment to the falx cerebri. Near the groove are several depressions, best marked in the skulls of old persons, for the arachnoid granulations, Pacchionian bodies. In the groove is the internal opening of the parietal foramen when the aperture exists. Borders. The sagittal border, the longest and thickest, is dentated and articulates with its fellow of the opposite side, forming the sagittal suture. The squamous border is divided into three parts. Of these, the anterior is thin and pointed, beveled at the expense of the outer surface, and overlapped by the tip of the great wing of the sphenoid. The middle portion is arched, beveled at the expense of the outer surface, and overlapped by the squama of the temporal. The posterior part is thick and serrated for articulation with the mastoid portion of the temporal. The frontal border is deeply serrated and beveled at the expense of the outer surface above and of the inner below. It articulates with the frontal bone, forming one half of the coronal suture. The occipital border, deeply denticulated, articulates with the occipital, forming one half of the lambdoidal suture. Angles. The frontal angle is practically a right angle, and corresponds with the point of meeting of the sagittal and coronal sutures. This point is named the bregma. In the fetal skull, and for about a year and a half after birth, this region is membranous, and is called the anterior fontanelle. The sphenoidal angle, thin and acute, is received into the interval between the frontal bone and the great wing of the sphenoid. Its inner surface is marked by a deep groove, sometimes a canal, for the anterior divisions of the middle meningeal artery. The occipital angle is rounded, and corresponds with the point of meeting of the sagittal and lambdoidal sutures, a point which is termed the lambda. In the fetus this part of the skull is membranous, and is called the posterior fontanelle. The mastoid angle is truncated. It articulates with the occipital bone and with the mastoid portion of the temporal, and presents on its inner surface a broad, shallow groove which lodges part of the transverse sinus. The point of meeting of this angle with the occipital and mastoid part of the temporal is named the asterion. Ossification. The parietal bone is ossified in membrane from a single center, which appears at the parietal eminence about the 8th week of fetal life. Ossification gradually extends in a radial manner from the center toward the margins of the bone. The angles are consequently the parts last formed, and it is here that the fontanelles exist. Occasionally the parietal bone is divided into two parts, upper and lower, by an antero-posterior suture. Articulations. The parietal articulates with 5 bones: the opposite parietal, the occipital, frontal, temporal, and sphenoid. The frontal bone, os frontale. The frontal bone resembles a cockle shell in form, and consists of 2 portions: a vertical portion, the squama, corresponding with the region of the forehead, and an orbital or horizontal portion, which enters into the formation of the roofs of the orbital and nasal cavities. Squama, squama frontalis. Surfaces. The external surface of this portion is convex, and usually exhibits, in the lower part of the middle line, the remains of the frontal or metopic suture. In infancy, this suture divides the bone into 2, a condition which may persist throughout life. On either side of this suture, about 3 cm above the supraorbital margin, is a rounded elevation, the frontal eminence, tuber frontale. These eminences vary in size in different individuals, are occasionally unsymmetrical, and are especially prominent in young skulls. The surface of the bone above them is smooth, and covered by the galea aponeurotica. Below the frontal eminences, and separated from them by a shallow groove, are 2 arched elevations, the superciliary arches. These are prominent medially, and are joined to one another by a smooth elevation named the glabella. They are larger in the male than in the female, and their degree of prominence depends to some extent on the size of the frontal air sinuses. Footnote: some confusion is occasioned to students commencing the study of anatomy by the name sinus having been given to 2 different kinds of space connected with the skull. It may be as well, therefore, to state here that the sinuses in the interior of the cranium which produce the grooves on the inner surfaces of the bones are venous channels which convey the blood from the brain, while the sinuses external to the cranial cavity, the frontal, sphenoidal, ethmoidal, and maxillary, are hollow spaces in the bones themselves. They communicate with the nasal cavities and contain air. End footnote. Prominent ridges are, however, occasionally associated with small air sinuses. Beneath each superciliary arch is a curved and prominent margin, the supraorbital margin, which forms the upper boundary of the base of the orbit, and separates the squama from the orbital portion of the bone. The lateral part of this margin is sharp and prominent, affording to the eye, in that situation, considerable protection from injury. The medial part is rounded. At the junction of its medial and intermediate thirds is a notch, sometimes converted into a foramen, the supraorbital notch or foramen, which transmits the supraorbital vessels and nerve. A small aperture in the upper part of the notch transmits a vein from the dipoi to join the supraorbital vein. The supraorbital margin ends laterally in the zygomatic process, which is strong and prominent, and articulates with the zygomatic bone. Running upward and backward from this process is a well-marked line, the temporal line, which divides into the upper and lower temporal lines, continuous, in the articulated skull, with the corresponding lines on the parietal bone. The area below and behind the temporal line forms the anterior part of the temporal fossa, and gives origin to the temporalis muscle. Between the supraorbital margins, the squama projects downward to a level below that of the zygomatic processes. This portion is known as the nasal part, and presents a rough, uneven interval, the nasal notch, which articulates on either side of the middle line with the nasal bone, and laterally with the frontal process of the maxilla and with the lacrimal. The term nation is applied to the middle of the frontonasal suture. From the center of the notch, the nasal process projects downward and forward
beneath the nasal bones and frontal processes of the maxillae, and supports the bridge of the nose. The nasal process ends below in a sharp spine, and on either side of this is a small grooved surface, which enters into the formation of the roof of the corresponding nasal cavity. The spine forms part of the septum of the nose, articulating in front with the crest of the nasal bones, and behind with the perpendicular plate of the ethmoid. The internal surface of the squama is concave, and presents in the upper part of the middle line a vertical groove, the sagittal sulcus, the edges of which unite below to form a ridge, the frontal crest. The sulcus lodges the superior sagittal sinus, while its margins and the crest afford attachment to the falx cerebri. The crest ends below in a small notch which is converted into a foramen, the foramen cecum, by articulation with the ethmoid. This foramen varies in size in different subjects, and is frequently impervious. When open, it transmits a vein from the nose to the superior sagittal sinus. On either side of the middle line, the bone presents depressions for the convolutions of the brain, and numerous small furrows for the anterior branches of the middle meningeal vessels. Several small irregular fossae may also be seen on either side of the sagittal sulcus, for the reception of the arachnoid granulations. Orbital or horizontal part. Pars orbitalis. This portion consists of two thin triangular plates, the orbital plates, which form the vaults of the orbits, and are separated from one another by a median gap, the ethmoidal notch. Surfaces. The inferior surface of each orbital plate is smooth and concave, and presents laterally, under cover of the zygomatic process, a shallow depression, the lacrimal fossa, for the lacrimal gland. Near the nasal part is a depression, the fovea trochlearis, or occasionally a small trochlear spine, for the attachment of the cartilaginous pulley of the obliquus oculi superior. The superior surface is convex, and marked by depressions for the convolutions of the frontal lobes of the brain, and faint grooves for the meningeal branches of the ethmoidal vessels. The ethmoidal notch separates the two orbital plates. It is quadrilateral, and filled in the articulated skull by the cribriform plate of the ethmoid. The margins of the notch present several half cells, which, when united with corresponding half cells on the upper surface of the ethmoid, complete the ethmoidal air cells. Two grooves cross these edges transversely. They are converted into the anterior and posterior ethmoidal canals by the ethmoid, and open on the medial wall of the orbit. The anterior canal transmits the nasociliary nerve and anterior ethmoidal vessels, the posterior ethmoidal nerve and vessels. In front of the ethmoidal notch, on either side of the frontal spine, are the openings of the frontal air sinuses. These are two irregular cavities, which extend backward, upward, and lateralward for a variable distance between the two tables of the skull. They are separated from one another by a thin, bony septum, which often deviates to one or other side, with the result that the sinuses are rarely symmetrical. Absent at birth, they are usually fairly well developed between the 7th and 8th years, but only reach their full size after puberty. They vary in size in different persons, and are larger in men than in women. Footnote: Aldrin Turner, The Accessory Sinuses of the Nose, 1901, gives the following measurements for a sinus of average size: height 1 1/4 inches, breadth 1 inch, depth from before backward 1 inch. End footnote. They are lined by mucous membrane, and each communicates with the corresponding nasal cavity by means of a passage called the frontal nasal duct. Borders. The border of the squama is thick, strongly serrated, beveled at the expense of the inner table above, where it rests upon the parietal bones, and at the expense of the outer table on either side, where it receives the lateral pressure of those bones. This border is continued below into a triangular rough surface, which articulates with the great wing of the sphenoid. The posterior borders of the orbital plates are thin and serrated, and articulate with the small wings of the sphenoid. Structure. The squama and the zygomatic processes are very thick, consisting of diploic tissue contained between two compact laminae. Diploic tissue is absent in the regions occupied by the frontal air sinuses. The orbital portion is thin, translucent, and composed entirely of compact bone. Hence, the facility with which instruments can penetrate the cranium through this part of the orbit. When the frontal sinuses are exceptionally large, they may extend backward for a considerable distance into the orbital portion, which in such cases also consists of only two tables. Ossification. The frontal bone is ossified in membrane from two primary centers, one for each half, which appear toward the end of the second month of fetal life, one above each supraorbital margin. From each of these centers, ossification extends upward to form the corresponding half of the squama, and backward to form the orbital plate. The spine is ossified from a pair of secondary centers, on either side of the middle line. Similar centers appear in the nasal part and zygomatic processes. At birth the bone consists of two pieces, separated by the frontal suture, which is usually obliterated, except at its lower part, by the 8th year, but occasionally persists throughout life. It is generally maintained that the development of the frontal sinuses begins at the end of the first or beginning of the second year, but Onodi's researches indicate that development begins at birth. The sinuses are of considerable size by the 7th or 8th year, but do not attain the full proportions until after puberty. Articulations. The frontal articulates with 12 bones: the sphenoid, the ethmoid, the two parietals, the two nasals, the two maxillae, the two lacrymals, and the two zygomatics. End of section 21. Recording by Jennifer Stearns, Concord, New Hampshire.
Section 22 of Gray's Anatomy, Part 1. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information, or to volunteer, please visit LibriVox.org. Recording by David Lawrence. Anatomy of the Human Body, Part 1, by Henry Gray. The Temporal Bone, Part 1. Os temporale. The temporal bones are situated at the sides and base of the skull. Each consists of 5 parts, viz., the squama, the petrous, mastoid, and tympanic parts, and the styloid process. The squama temporalis. The squama forms the anterior and upper part of the bone and is scale-like, thin, and translucent. Surfaces. Its outer surface is smooth and convex. It affords attachment to the temporalis muscle, and forms part of the temporal fossa. On its hinder part is a vertical groove for the middle temporal artery. A curved line, the temporal line, or supramastoid crest, runs backward and upward across its posterior part. It serves for the attachment of the temporal fascia, and limits the origin of the temporalis muscle. The boundary between the squama and the mastoid portion of the bone, as indicated by traces of the original suture, lies about 1 centimeter below this line. Projecting from the lower part of the squama is a long arched process, the zygomatic process. This process is at first directed lateralward, its two surfaces looking upward and downward. It then appears as if twisted inward upon itself, and runs forward, its surfaces now looking medialward and lateralward. The superior border is long, thin, and sharp, and serves for the attachment of the temporal fascia. The inferior, short, thick, and arched, has attached to it some fibers of the masseter. The lateral surface is convex and subcutaneous. The medial is concave and affords attachment to the masseter. The anterior end is deeply serrated and articulates with the zygomatic bone. The posterior end is connected to the squama by two roots, the anterior and posterior roots. The posterior root, a prolongation of the upper border, is strongly marked. It runs backward across the external acoustic meatus, and is continuous with the temporal line. The anterior root, continuous with the lower border, is short but broad and strong. It is directed medialward and ends in a rounded eminence. The articular tubercle, eminentia articularis. This tubercle forms the front boundary of the mandibular fossa, and in the fresh state is covered with cartilage. In front of the anticular tubercle is a small triangular area which assists in forming the infratemporal fossa. This area is separated from the outer surface of the squama by a ridge which is continuous behind, with the anterior root of the zygomatic process, and in front, in the articulated skull, with the infratemporal crest on the great wing of the sphenoid. Between the posterior wall of the external acoustic meatus and the posterior root of the zygomatic process is the area called the suprameatal triangle, or mastoid fossa, through which an instrument may be pushed into the tympanic antrum. At the junction of the anterior root with the zygomatic process is a projection for the attachment of the temporomandibular ligament, and behind the anterior root is an oval depression, forming part of the mandibular fossa, for the reception of the condyle of the mandible. The mandibular fossa, glenoid fossa, is bound in front by the articular tubercle, behind by the tympanic part of the bone, which separates it from the external acoustic meatus. It is divided into two parts by a narrow slit, the petrotympanic fissure, Glaserian fissure. The anterior part, formed by the squama, is smooth, covered in the fresh state with cartilage, and articulates with the condyle of the mandible. Behind this part of the fossa is a small conical eminence. This is the representative of a prominent tubercle, which, in some mammals, descends behind the condyle of the mandible, and prevents its backward displacement. The posterior part of the mandibular fossa, formed by the tympanic part of the bone, is non-articular, and sometimes lodges a portion of the parotid gland. The petrotympanic fissure leads into the middle ear or tympanic cavity. It lodges the anterior process of the malleus, and transmits the tympanic branch of the anterior maxillary artery. The chorda tympani nerve passes through a canal of Hugulaire, separated from the anterior edge of the petrotympanic fissure by a thin scale of bone, and situated on the lateral side of the auditory tube, in a retiring angle between the squama and the petrous portion of the temporal. The internal surface of the squama is concave. It presents depressions corresponding to the convolutions of the temporal lobe of the brain, and grooves for the branches of the middle meningeal vessels. Borders. The superior border is thin and beveled at the expense of the internal table, so as to overlap the squamous border of the parietal bone, forming with it the squamosal suture. Posteriorly, the superior border forms an angle, the parietal notch, with the mastoid portion of the bone. The antero-inferior border is thick, serrated, and beveled at the expense of the inner table above and of the outer below, for articulation with the great wing of the sphenoid. Mastoid portion, pars mastoidea. The mastoid portion forms the posterior part of the bone. Surfaces. Its outer surface is rough and gives attachment to the occipitalis and auricularis posterior. It is perforated by numerous foramina. One of these, of large size, situated near the posterior border, is termed the mastoid foramen. It transmits the vein to the transverse sinus and a small branch of the occipital artery to the dura mater. The position and size of this foramen are very variable. It is not always present. Sometimes it is situated in the occipital bone, or in the suture between the temporal and the occipital. The mastoid portion is continued below into a conical projection, the mastoid process, the size and form of which varies somewhat. It is larger in the male than in the female. This process serves for the attachment of the sternocleidomastoideus, splenius capitis, and the longissimus capitis. On the medial side of the process is a deep groove, the mastoid notch, digastric fossa, for the attachment of the digastricus. Medial to this is a shallow furrow, the occipital groove, which lodges the occipital artery. The inner surface of the mastoid portion presents a deep curved groove, the sigmoid sulcus, which lodges part of the transverse sinus. In it may be seen the opening of the mastoid foramen. The groove for the transverse sinus is separated from the innermost of the mastoid air cells by a very thin lamina of bone, and even this may be partially deficient. Borders. The superior border of the mastoid portion is broad and serrated, for articulation with the mastoid angle of the parietal. The posterior border, also serrated, articulates with the inferior border of the occipital between the lateral angle and the jugular process. Anteriorly, the mastoid portion is fused with the descending process of the squama above. Below, it enters into the formation of the external acoustic meatus and the tympanic cavity. A section of the mastoid process shows it to be hollowed out into a number of spaces, the mastoid cells, which exhibit the greatest possible variety as to their size and number. At the upper and front part of the process, they are large and irregular, and contain air. But toward the lower part they diminish in size, while those at the apex of the process are frequently quite small and contain marrow. Occasionally they are entirely absent, and the mastoid is then solid throughout. In addition to these, a large irregular cavity is situated at the upper and front part of the bone. It is called the tympanic antrum, and must be distinguished from the mastoid cells, though it communicates with them. Like the mastoid cells, it is filled with air and lined by a prolongation of the mucous membrane of the tympanic cavity, with which it communicates. The tympanic antrum is bound above by a thin plate of bone, the tegmen tympani, which separates it from the middle fossa of the base of the skull. Below, by the mastoid process; laterally, by the squama just below the temporal line; and medially, by the lateral semicircular canal of the inner ear, which projects into its cavity. It opens in front into that portion of the tympanic cavity which is known as the attic, or epitympanic recess. The tympanic antrum is a cavity of some considerable size at the time of birth. The mastoid air cells may be regarded as diverticula from the antrum, and begin to appear at or before birth. By the 5th year they are well marked, but their development is not completed until toward puberty. End of section 22. Recorded by David Lawrence in Brampton, Ontario, September 2008.
Of Gray's Anatomy, Part 1. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recording by Morgan Scorpion. Anatomy of the Human Body, Part 1, by Henry Gray. The Temporal Bone, Part 2. Petrous portion, Pars petrosa, pyramis. The petrous portion, or pyramid, is pyramidal and is wedged in at the base of the skull between the sphenoid and occipital. Directed medialward, forward, and a little upward, it presents for examination a base, an apex, 3 surfaces, and 3 angles, and contains in its interior the essential parts of the organ of hearing. Base. The base is fused with the internal surfaces of the squama and mastoid portion. Apex. The apex, rough and uneven, is received into the angular interval between the posterior border of the great wing of the sphenoid and the basilar part of the occipital. It presents the anterior or internal orifice of the carotid canal and forms the posterolateral boundary of the forum lacerum. Surfaces. The anterior surface forms the posterior part of the middle fossa of the base of the skull, and is continuous with the inner surface of the squamous portion, to which it is united by the petrosquamous suture, remains of which are distinct even at a late period of life. It is marked by depressions for the convolutions of the brain, and presents 6 points for examination. 1. Near the centre, an eminence, eminentia arcuata, which indicates the situation of the superior semicircular canal. 2. In front of and a little lateral to this eminence, a depression indicating the position of the tympanic cavity. Here the layer of bone which separates the tympanic from the cranial cavity is extremely thin, and is known as the tegmen tympani. 3. A shallow groove, sometimes double, leading lateralwards and backwards to an oblique opening, the hiatus of the facial canal, for the passage of the greater superficial petrosal nerve and the petrosal branch of the middle meningeal artery. 4. Lateral to the hiatus, a smaller opening, occasionally seen, for the passage of the lesser superficial petrosal nerve. 5. Near the apex of the bone, the termination of the carotid canal, the wall of which in this situation is deficient in front. 6. Above this canal the shallow trigeminal impression for the reception of the semilunar ganglion. The posterior surface, Fig. 138, forms the front portion of the posterior fossa of the base of the skull and is continuous with the inner surface of the mastoid portion. Near the centre is a large orifice, the internal acoustic meatus, the size of which varies considerably. Its margins are smooth and rounded, and it leads into a short canal about 1 cm in length, which runs lateralward. It transmits the facial and acoustic nerves and the internal auditory branch of the basilar artery. The lateral end of the canal is closed by a vertical plate, which is divided by a horizontal crest, the crista falciformis, into 2 unequal portions. Fig. 140. Each portion is further subdivided by a vertical ridge into an anterior and a posterior part. In the portion beneath the crista falciformis are 3 sets of foramina. One group, just below the posterior part of the crest, situated in the area cribrosa media, consists of several small openings for the nerves to the saccule. Below and behind this area is the foramen singulare, or opening for the nerve to the posterior semicircular duct. In front of and below the first is the tractus spiralis foraminosus, consisting of a number of small spirally arranged openings, which encircle the canalis centralis cochleae. These openings together with the central canal transmit the nerves to the cochlea. The portion above the crista falciformis presents behind the area cribrosa superior, pierced by a series of small openings, for the passage of the nerves to the utricle and the superior and lateral semicircular ducts, and in front the area faciens, with one large opening, the commencement of the canal for the facial nerve, aqueductus fallopii. Behind the internal acoustic meatus is a small slit almost hidden by a thin plate of bone, leading to a canal, the aqueductus vestibuli, which transmits the ductus endolymphaticus together with a small artery and vein. Above and between these 2 openings is an irregular depression which lodges a process of the dura mater and transmits a small vein. In the infant this depression is represented by a large fossa, the subarcuate fossa, which extends backwards as a blind tunnel under the superior semicircular canal. The inferior surface, Fig. 141, is rough and irregular, and forms part of the exterior of the base of the skull. It presents 11 points for examination. 1. Near the apex is a rough surface, quadrilateral in form, which serves partly for the attachment of the levator veli palatini and the cartilaginous portion of the auditory tube, and partly for connection with the basilar part of the occipital bone through the intervention of some dense fibrous tissue. 2. Behind this is the large circular aperture of the carotid canal, which descends at first vertically, and then, making a bend, runs horizontally forward and medialward. It transmits into the cranium the internal carotid artery, and the carotid plexus of nerves. 3. Medial to the opening for the carotid canal and close to its posterior border, in front of the jugular fossa, is a triangular depression. At the apex of this is a small opening, the aqueductus cochleae, which lodges a tubular prolongation of the dura mater, establishing a communication between the perilymphatic space and the subarachnoid space, and transmits a vein from the cochlea to join the internal jugular. 4. Behind these openings is a deep depression, the jugular fossa, of variable depth and size in different skulls. It lodges the bulb of the internal jugular vein. 5. In the bony ridge dividing the carotid canal from the jugular fossa is a small inferior tympanic canaliculus, for the passage of the tympanic branch of the glossopharyngeal nerve. 6. In the lateral part of the jugular fossa is the mastoid canaliculus, for the entrance of the auricular branch of the vagus nerve. 7. Behind the jugular fossa is a quadrilateral area, the jugular surface, covered with cartilage in the fresh state, and articulating with the jugular process of the occipital bone. 8. Extending backward from the carotid canal is the vaginal process, a sheath-like plate of bone which divides behind into two laminae. The lateral lamina is continuous with the tympanic part of the bone, the medial with the lateral margin of the jugular surface. 9. Between these laminae is the styloid process, a sharp spine about 2.5 cm in length. 10. Between the styloid and mastoid processes is the stylomastoid foramen. It is the termination of the facial canal and transmits the facial nerve and stylomastoid artery. 11. Situated between the tympanic portion and the mastoid process is the tympanomastoid fissure, for the exit of the auricular branch of the vagus nerve. Angles. The superior angle, the longest, is grooved for the superior petrosal sinus, and gives attachment to the tentorium cerebelli. At its medial extremity is a notch, in which the trigeminal nerve lies. The posterior angle is intermediate in length between the superior and the anterior. Its medial half is marked by a sulcus, which forms, with a corresponding sulcus on the occipital bone, the channel for the inferior petrosal sinus. Its lateral half presents an excavation, the jugular fossa, which, with the jugular notch on the occipital, forms the jugular foramen. An eminence occasionally projects from the centre of the fossa and divides the foramen into two. The anterior angle is divided into two parts: a lateral joined to the squama by a suture, petrosquamus, the remains of which are more or less distinct; a medial, free, which articulates with the spinous process of the sphenoid. At the angle of junction of the petrous part and the squama are two canals, one above the other, and separated by a thin plate of bone, the septum canalis musculotubarii, processus cochleariformis. Both canals lead into the tympanic cavity. The upper one, semicanalis tensoris tympani, transmits the tensor tympani. The lower one, semicanalis tubi auditativae, forms the bony part of the auditory tube. The tympanic cavity, auditory ossicles, and internal ear are described with the organ of hearing. Tympanic part, pars tympanica. The tympanic part is a curved plate of bone lying below the squama and in front of the mastoid process. Surfaces. Its postero-superior surface is concave, and forms the anterior wall, the floor and part of the posterior wall of the bony external acoustic meatus. Medially, it presents a narrow furrow, the tympanic sulcus, for the attachment of the tympanic membrane. Its antero-inferior surface is quadrilateral and slightly concave. It constitutes the posterior boundary of the mandibular fossa, and is in contact with the retromandibular part of the parotid gland. Borders. Its lateral border is free and rough, and gives attachment to the cartilaginous part of the external acoustic meatus. Internally, the tympanic part is fused with the petrous portion, and appears in the retreating angle between it and the squama, where it lies below and lateral to the orifice of the auditory tube. Posteriorly it blends with the squama and mastoid part, and forms the anterior boundary of the tympanomastoid fissure. Its upper border fuses laterally with the back of the postglenoid process, while medially it bounds with the petrotympanic fissure. The medial part of the lower border is thin and sharp. Its lateral part splits to enclose the root of the styloid process, and is therefore named the vaginal process. The central portion of the tympanic part is thin, and in a considerable percentage of skulls is perforated by a hole, the foramen of Huschke. The external acoustic meatus is nearly 2 centimeters long and is directed inwards and slightly forward. At the same time it forms a slight curve, so that the floor of the canal is convex upward. In sagittal section it presents an oval or elliptical shape, with the long axis directed downward and slightly backward. Its anterior wall and floor and the lower part of its posterior wall are formed by the tympanic part, the roof and upper part of the posterior wall by the squama. Its inner end is closed, in the recent state, by the tympanic membrane. The upper limit of its outer orifice is formed by the posterior root of the zygomatic process, immediately below which there is sometimes seen a small spine, the suprameatal spine, situated at the upper and posterior part of the orifice. Styloid process, Processus styloideus. The styloid process is slender, pointed, and of varying length. It projects downwards and forwards from the under surface of the temporal bone. Its proximal part, tympanohyal, is ensheathed by the vaginal process of the tympanic portion, while its distal part, stylohyal, gives attachment to the stylohyoid and stylomandibular ligaments, and to the styloglossus, stylohyoideus, and stylopharyngeus muscles. The stylohyoid ligament extends from the apex of the process to the letter cornu of the hyoid bone, and in some instances is partially, in others completely, ossified. Structure. The structure of the squama is like that of the other cranial bones. The mastoid portion is spongy, and the petrous portion is dense and hard. Ossification. The temporal bone is ossified from 8 centres, exclusive of those for the internal ear and the tympanic ossicles, viz., 1 for the squama including the zygomatic process, 1 for the tympanic part, 4 for the petrous and mastoid parts, and 2 for the styloid process. Just before the close of fetal life, Fig. 142, the temporal bone consists of 3 principal parts. 1. The squama is ossified in membrane from a single nucleus, which appears near the root of the zygomatic process about the 2nd month. 2. The petromastoid part is developed from 4 centres, which make their appearance in a cartilaginous ear capsule about the 5th or 6th month. 1. Prootic, appears in the neighbourhood of the eminentia arcuata, spreads in front and above the internal acoustic meatus, and extends to the apex of the bone. It forms part of the cochlea, vestibule, superior semicircular canal, and medial wall of the tympanic cavity. A second, opisthotic, appears at the promontory of the medial wall of the tympanic cavity and surrounds the fenestra cochleae. It forms the floor of the tympanic cavity and vestibule, surrounds the carotid canal, invests the lateral and lower part of the cochlea, and spreads medially below the internal acoustic meatus. A third, pterotic, roofs in the tympanic cavity and antrum, while the fourth, epiotic, appears near the posterior semicircular canal and extends to form the mastoid process. Frolic. 3. The tympanic ring is an incomplete circle, in the concavity of which is a groove, the tympanic sulcus, for the attachment of the circumference of the tympanic membrane. This ring expands to form the tympanic part, and is ossified in membrane from a single centre which appears about the 3rd month. The styloid process is developed from the proximal part of the cartilage of the 2nd branchial or hyoid arch by 2 centres. 1 for the proximal part, the tympanohyal, appears before birth. The other, comprising the rest of the process, is named the stylohyal, and does not appear until after birth. The tympanic ring unites with the squama shortly before birth. The pteromastoid part and squama join during the 1st year, and the tympanohyal portion of the styloid process about the same time. Figures 143 and 144. The stylohyal does not unite with the rest of the bone until after puberty, and in some skulls never at all. The chief subsequent changes in the temporal bone apart from increase in size are 1. The tympanic ring extends outwards and backwards to form the tympanic part. This extension does not, however, take place at an equal rate all round the circumference of the ring, but occurs most rapidly on its anterior and posterior portions. And these outgrowths meet and blend, and thus for a time there exists in the floor of the meatus a foramen, the foramen of Huschke. This foramen is usually closed about the 5th year, but may persist throughout life. 2. The mandibular fossa is at first extremely shallow, and looks lateralward as well as downward. it becomes deeper and ultimately directed downward. Its change in direction is accounted for as follows. The part of the squama which forms the fossa lies at first below the level of the zygomatic process. As, however, the base of the skull increases in width, this lower part of the squama is directed horizontally inward to contribute to the middle fossa of the skull, and its surfaces therefore come to look upward and downward. The attached portion of the zygomatic process also becomes everted, and projects like a shelf at right angles to the squama. 3. The mastoid portion is at first quite flat, and the stylomastoid foramen and rudimentary styloid process lie immediately behind the tympanic ring. With the development of the air cells, the outer part of the mastoid portion grows downward and forward to form the mastoid process, and the styloid process and stylomastoid foramen now come to lie on the under surface. The descent of the foramen is necessarily accompanied by a corresponding lengthening of the facial canal. 4. The downward and forward growth of the mastoid process also pushes forward the tympanic part, so that the portion of it which formed the original floor of the meatus and contained the foramen of Huschka is ultimately found in the interior wall. 5. The fossa subarcuata becomes filled up and almost obliterated. Articulations. The temporal articulates with 5 bones: occipital, parietal, sphenoid, mandible, and zygomatic. End of section 23.
24 of Gray's Anatomy, Part 1. This is a LibriVox recording. All LibriVox recordings are in the public domain. For more information or to volunteer, please visit LibriVox.org. Recorded by Laurie Ann Walden. Anatomy of the Human Body, Part 1, by Henry Gray. The sphenoid bone, os sphenoidale. The sphenoid bone is situated at the base of the skull in front of the temporals and basilar part of the occipital. It somewhat resembles a bat with its wings extended, and is divided into a median portion or body, 2 great and 2 small wings extending outward from the sides of the body, and 2 pterygoid processes which project from it below. Body, corpus sphenoidale. The body, more or less cubical in shape, is hollowed out in its interior to form 2 large cavities, the sphenoidal air sinuses, which are separated from each other by a septum. Surfaces. The superior surface of the body presents in front a prominent spine, the ethmoidal spine, for articulation with the cribriform plate of the ethmoid. Behind this is a smooth surface slightly raised in the middle line, and grooved on either side for the olfactory lobes of the brain. This surface is bounded behind by a ridge, which forms the anterior border of a narrow transverse groove, the chiasmatic groove, or optic groove, above and behind which lies the optic chiasma. The groove ends on either side in the optic foramen, which transmits the optic nerve and ophthalmic artery into the orbital cavity. Behind the chiasmatic groove is an elevation, the tuberculum sellae, and still more posteriorly a deep depression, the sella turcica, the deepest part of which lodges the hypophysis cerebri and is known as the fossa hypophyseus. The anterior boundary of the sella turcica is completed by 2 small eminences, one on either side, called the middle clinoid processes, while the posterior boundary is formed by a square-shaped plate of bone, the dorsum celli, ending at its superior angles in 2 tubercles, the posterior clinoid processes, the size and form of which vary considerably in different individuals. The posterior clinoid processes deepen the sella turcica, and give attachment to the tentorium cerebelli. On either side of the dorsum celli is a notch for the passage of the abducent nerve, and below the notch a sharp process, the petrosal process, which articulates with the apex of the petrous portion of the temporal bone, and forms the medial boundary of the foramen lacerum. Behind the dorsum celli is a shallow depression, the clevus, which slopes obliquely backward and is continuous with the groove on the basilar portion of the occipital bone. It supports the upper part of the pons. The lateral surfaces of the body are united with the great wings and the medial pterygoid plates. Above the attachment of each great wing is a broad groove, curved something like the italic letter F. It lodges the internal carotid artery and the cavernous sinus, and is named the carotid groove. Along the posterior part of the lateral margin of this groove, in the angle between the body and great wing, is a ridge of bone called the lingula. The posterior surface, quadrilateral in form, is joined, during infancy and adolescence, to the basilar part of the occipital bone by a plate of cartilage. Between the 18th and 25th years this becomes ossified, ossification commencing above and extending downward. The anterior surface of the body presents, in the middle line, a vertical crest, the sphenoidal crest, which articulates with the perpendicular plate of the ethmoid and forms part of the septum of the nose. On either side of the crest is an irregular opening leading into the corresponding sphenoidal air sinus. These sinuses are two large irregular cavities hollowed out of the interior of the body of the bone, and separated from one another by a bony septum, which is commonly bent to one or the other side. They vary considerably in form and size, are seldom symmetrical, and are often partially subdivided by irregular bony laminae. Footnote: Aldrin Turner gives the following as their average measurements: vertical height 7/8 inch, antero-posterior depth 7/8 inch, transverse breadth 3/4 inch. End footnote. Occasionally they extend into the basilar part of the occipital nearly as far as the foramen magnum. They begin to be developed before birth, and are of a considerable size by the age of 6. They are partially closed, in front and below, by two thin, curved plates of bone, the sphenoidal conchae, leaving in the articulated skull a round opening at the upper part of each sinus, by which it communicates with the upper and back part of the nasal cavity, and occasionally with the posterior ethmoidal air cells. The lateral margin of the anterior surface is serrated, and articulates with the lamina papyracea of the ethmoid, completing the posterior ethmoidal cells. The lower margin articulates with the orbital process of the palatine bone, and the upper with the orbital plate of the frontal bone. The inferior surface presents, in the middle line, a triangular spine, the sphenoidal rostrum, which is continuous with the sphenoidal crest on the anterior surface, and is received in a deep fissure between the alae of the vomer. On either side of the rostrum is a projecting lamina, the vaginal process, directed medialward from the base of the medial pterygoid plate, with which it will be described. The great wings, ali magni. The great wings, or alisphenoids, are two strong processes of bone, which arise from the sides of the body, and are curved upward, lateralward, and backward. The posterior part of each projects as a triangular process which fits into the angle between the squama and the petrous portion of the temporal, and presents at its apex a downwardly directed process, the spina angularis, or sphenoidal spine. Surfaces. The superior or cerebral surface of each great wing forms part of the middle fossa of the skull. It is deeply concave, and presents depressions for the convolutions of the temporal lobe of the brain. At its anterior and medial part is a circular aperture, the foramen rotundum, for the transmission of the maxillary nerve. Behind and lateral to this is the foramen ovale, for the transmission of the mandibular nerve, the accessory meningeal artery, and sometimes the lesser superficial petrosal nerve. Footnote: The lesser superficial petrosal nerve sometimes passes through a special canal, canaliculus innominatus of Arnold, situated medial to the foramen spinosum. End footnote. Medial to the foramen ovale, a small aperture, the foramen vessalii, may occasionally be seen opposite the root of the pterygoid process. It opens below near the scaphoid fossa, and transmits a small vein from the cavernous sinus. Lastly, in the posterior angle, near to and in front of the spine, is a short canal, sometimes double, the foramen spinosum, which transmits the medial meningeal vessels and a recurrent branch from the mandibular nerve. The lateral surface is convex and divided by a transverse ridge, the infratemporal crest, into two portions. The superior or temporal portion, convex from above downward, concave from before backward, forms a part of the temporal fossa, and gives attachment to the temporalis. The inferior or infratemporal, smaller in size and concave, enters into the formation of the infratemporal fossa, and, together with the infratemporal crest, affords attachment to the pterygoideus externus. It is pierced by the foramen ovale and foramen spinosum, and at its posterior part is the spina angularis, which is frequently grooved on its medial surface for the chorda tympani nerve. To the spina angularis are attached the sphenomandibular ligament and the tensor veli palatini. Medial to the anterior extremity of the infratemporal crest is a triangular process which serves to increase the attachment of the pterygoideus externus. Extending downward and medialward from this process onto the front part of the lateral pterygoid plate is a ridge which forms the anterior limit of the infratemporal surface and, in the articulated skull, the posterior boundary of the pterygomaxillary fissure. The orbital surface of the great wing, smooth and quadrilateral in shape, is directed forward and medialward and forms the posterior part of the lateral wall of the orbit. Its upper serrated edge articulates with the orbital plate of the frontal. Its inferior rounded border forms the posterolateral boundary of the inferior orbital fissure. Its medial sharp margin forms the lower boundary of the superior orbital fissure and has projecting from about its center a little tubercle which gives attachment to the inferior head of the rectus lateralis oculi. At the upper part of this margin is a notch for the transmission of a recurrent branch of the lacrimal artery. Its lateral margin is serrated and articulates with the zygomatic bone. Below the medial end of the superior orbital fissure is a grooved surface which forms the posterior wall of the pterygopalatine fossa and is pierced by the foramen rotundum. Margin. Commencing from behind, that portion of the circumference of the great wing which extends from the body to the spine is irregular. Its medial half forms the anterior boundary of the foramen lacerum, and presents the posterior aperture of the pterygoid canal for the passage of the corresponding nerve and artery. Its lateral half articulates, by means of a synchondrosis, with the petrous portion of the temporal, and between the two bones on the under surface of the skull is a furrow, the sulcus tubi, for the lodgment of the cartilaginous part of the auditory tube. In front of the spine the circumference presents a concave serrated edge, beveled at the expense of the inner table below and of the outer table above, for articulation with the temporal squama. At the tip of the great wing is a triangular portion, beveled at the expense of the internal surface, for articulation with the sphenoidal angle of the parietal bone. This region is named the pterion. Medial to this is a triangular serrated surface for articulation with the frontal bone. This surface is continuous medially with the sharp edge, which forms the lower boundary of the superior orbital fissure, and laterally with the serrated margin for articulation with the zygomatic bone. The small wings, ali parvi. The small wings, or orbitosphenoids, are two thin triangular plates, which arise from the upper and anterior parts of the body, and, projecting lateralward, end in sharp points. Surfaces. The superior surface of each is flat, and supports part of the frontal lobe of the brain. The inferior surface forms the back part of the roof of the orbit, and the upper boundary of the superior orbital fissure. This fissure is of a triangular form, and leads from the cavity of the cranium into that of the orbit. It is bounded medially by the body, above by the small wing, below by the medial margin of the orbital surface of the great wing, and is completed laterally by the frontal bone. It transmits the oculomotor, trochlear, and abducent nerves, the three branches of the ophthalmic division of the trigeminal nerve, some filaments from the cavernous plexus of the sympathetic, the orbital branch of the middle meningeal artery, a recurrent branch from the lacrimal artery to the dura mater, and the ophthalmic vein. Borders. The anterior border is serrated for articulation with the frontal bone. The posterior border, smooth and rounded, is received into the lateral fissure of the brain. The medial end of this border forms the anterior clinoid process, which gives attachment to the tentorium cerebelli. It is sometimes joined to the middle clinoid process by a spicule of bone, and when this occurs the termination of the groove for the internal carotid artery is converted into a foramen, carotico-clinoid. The small wing is connected to the body by two roots, the upper thin and flat, the lower thick and triangular. Between the two roots is the optic foramen, for the transmission of the optic nerve and ophthalmic artery. Pterygoid processes. Processus pterygoidii. The pterygoid processes, one on either side, descend perpendicularly from the regions where the body and great wings unite. Each process consists of a medial and a lateral plate, the upper parts of which are fused anteriorly. A vertical sulcus, the pterygo-palatine groove, descends on the front of the line of fusion. The plates are separated below by an angular cleft, the pterygoid fissure, the margins of which are rough for articulation with the pyramidal process of the palatine bone. The two plates diverge behind and enclose between them a V-shaped fossa, the pterygoid fossa, which contains the pterygoideus internus and tensor veli palatini. Above this fossa is a small, oval, shallow depression, the scaphoid fossa, which gives origin to the tensor veli palatini. The anterior surface of the pterygoid process is broad and triangular near its root, where it forms the posterior wall of the pterygo-palatine fossa, and presents the anterior orifice of the pterygoid canal. Lateral pterygoid plate. The lateral pterygoid plate is broad, thin, and everted. Its lateral surface forms part of the medial wall of the infratemporal fossa, and gives attachment to the pterygoideus externus. Its medial surface forms part of the pterygoid fossa, and gives attachment to the pterygoideus internus. Medial pterygoid plate. The medial pterygoid plate is narrower and longer than the lateral. It curves lateralward at its lower extremity into a hook-like process, the pterygoid hamulus, around which the tendon of the tensor veli palatini glides. The lateral surface of this plate forms part of the pterygoid fossa. The medial surface constitutes the lateral boundary of the choana, or posterior aperture of the corresponding nasal cavity. Superiorly, the medial plate is prolonged onto the undersurface of the body as a thin lamina, named the vaginal process, which articulates in front with the sphenoidal process of the palatine, and behind this with the ala of the vomer. The angular prominence between the posterior margin of the vaginal process and the medial border of the scaphoid fossa is named the pterygoid tubercle, and immediately above this is the posterior opening of the pterygoid canal. On the undersurface of the vaginal process is a furrow, which is converted into a canal by the sphenoidal process of the palatine bone, for the transmission of the pharyngeal branch of the internal maxillary artery and the pharyngeal nerve from the sphenopalatine ganglion. The pharyngeal aponeurosis is attached to the entire length of the posterior edge of the medial plate, and the constrictor pharyngeus superior takes origin from its lower third. Projecting backward from near the middle of the posterior edge of this plate is an angular process, the processus tubarius, which supports the pharyngeal end of the auditory tube. The anterior margin of the plate articulates with the posterior border of the vertical part of the palatine bone. The sphenoidal conchi, conchi sphenoidalis, sphenoidal turbinated processes. The sphenoidal conchi are two thin curved plates situated at the anterior and lower part of the body of the sphenoid. An aperture of variable size exists in the anterior wall of each, and through this the sphenoidal sinus opens into the nasal cavity. Each is irregular in form and tapers to a point behind, being broader and thinner in front. Its upper surface is concave and looks toward the cavity of the sinus. Its undersurface is convex and forms part of the roof of the corresponding nasal cavity. Each bone articulates in front with the ethmoid, laterally with the palatine. Its pointed posterior extremity is placed above the vomer, and is received between the root of the pterygoid process laterally and the rostrum of the sphenoid medially. A small portion of the sphenoidal concha sometimes enters into the formation of the medial wall of the orbit, between the lamina papyracea of the ethmoid in front, the orbital plate of the palatine below, and the frontal bone above. Ossification. Until the 7th or 8th month of fetal life, the body of the sphenoid consists of two parts, that is, one in front of the tuberculum celli, the pre-sphenoid, with which the small wings are continuous; the other comprising the sella turcica and dorsum celli, the post-sphenoid, with which are associated the great wings and pterygoid processes. The greater part of the bone is ossified in cartilage. There are 14 centers in all, 6 for the presphenoid and 8 for the postsphenoid. Presphenoid. About the 9th week of fetal life an ossific center appears for each of the small wings (orbitosphenoids) just lateral to the optic foramen. Shortly afterward 2 nuclei appear in the presphenoid part of the body. The sphenoidal conchae are each developed from a center which makes its appearance about the 5th month. At birth they consist of small triangular laminae, and it is not until the 3rd year that they become hollowed out and cone-shaped. About the 4th year they fuse with the labyrinths of the ethmoid, and between the 9th and 12th years they unite with the sphenoid. Footnote: according to Cleland, each sphenoidal concha is ossified from 4 centers. End footnote. Postsphenoid. The first ossific nuclei are those for the great wings, alisphenoids. Footnote: Mall, American Journal of Anatomy, 1906, states that the pterygoid center appears first in an embryo 57 days old. End footnote. One makes its appearance in each wing between the foramen rotundum and foramen ovale about the 8th week. The orbital plate and that part of the sphenoid which is found in the temporal fossa, as well as the lateral pterygoid plate, are ossified in membrane (faucet). Soon after, the centers for the postsphenoid part of the body appear, one on either side of the sella turcica, and become blended together about the middle of fetal life. Each medial pterygoid plate, with the exception of its hamulus, is ossified in membrane, and its center probably appears about the 9th or 10th week. The hamulus becomes chondrified during the 3rd month, and almost at once undergoes ossification (faucet). The medial joins the lateral pterygoid plate about the 6th month. About the 4th month a center appears for each lingula, and speedily joins the rest of the bone. The presphenoid is united to the postsphenoid about the 8th month, and at birth the bone is in 3 pieces: a central, consisting of the body and small wings, and 2 lateral, each comprising a great wing and pterygoid process. In the 1st year after birth the great wings and body unite, and the small wings extend inward above the anterior part of the body, and, meeting with each other in the middle line, form an elevated smooth surface termed the jugum sphenoidale. By the 25th year the sphenoid and occipital are completely fused. Between the pre- and postsphenoid there are occasionally seen the remains of a canal, the canalus craniopharyngeus, through which, in early fetal life, the hypophyseal diverticulum of the buccal ectoderm is transmitted. The sphenoidal sinuses are present as minute cavities at the time of birth (onody), but do not attain their full size until after puberty. Intrinsic ligaments of the sphenoid. The more important of these are the pterygospinous, stretching between the spina angularis and the lateral pterygoid plate (see cervical fascia), the interclinoid, a fibrous process joining the anterior to the posterior clinoid process, and the caroticoclinoid, connecting the anterior to the middle clinoid process. These ligaments occasionally ossify. Articulations. The sphenoid articulates with 12 bones: 4 single, the vomer, ethmoid, frontal, and occipital, and 4 paired, the parietal, temporal, zygomatic, and palatine. Footnote: it also sometimes articulates with the tuberosity of the maxilla. End footnote. End of section 24.